Well, welcome and thank you for coming here on a fairly cold, bleak evening. We were expecting others, but I think it's one of those nights. It's pretty, as I say, bleak out there. But we are delighted that you're here. I'm Alistair Burt. I'm head of the Faculty of Health and Medical Sciences at the University of Adelaide, and this is one of a number of regular Executive Dean's public lectures. I'd like to start by acknowledging the Ghana people, the original custodians of the Adelaide Plains and the land on which the university's campuses here, North Terrace, Waite, Theberton and Roseworthy are built. So I'm delighted that you are here tonight, and you're going to actually hear from three speakers. Not one, not two, but three. And so the speakers this evening are Professor Toby Coates, Dr. Robert Carroll and Dr. Shantanu Bhattacharya. How did I get it right? Good. So Professor Coates is one of our most successful, eminent title holders. He's a transplant nephrologist at the Royal Adelaide Hospital, so soon will be on the removal van on the way down North Terrace, along with the others. He completed his PhD in transplant immunology with us at the University of Adelaide and is currently a clinical pathology with us in the Adelaide Medical School. Dr. Carroll is also a transplant nephrologist at the Royal Adelaide Hospital and a senior lecturer in medicine. And one of his claims to fame is he established the only young adult renal clinic in Australia. And he's going to talk about the Australian paired kidney exchange scheme and how incompatible kidney donor couples can find a match by exchanging with other incompatible couples. Dr. Bhattacharya is a living donor transplant surgeon from the Royal Adelaide. He will discuss laparoscopic keyhole surgery for kidney donation, a technique which was first pioneered in Adelaide and which has revolutionised kidney donation and resulted in much speedier recovery for kidney transplant, for kidney donors. So to discuss advancements in living kidney donation, I'm delighted to introduce Dr. Coates, Professor Coates, Dr. Carroll, and Dr. Bhattacharya. Thank you.
Thank you, Alistair, and thanks everybody for coming out, as Alistair said, on a cold night to hear about living donor transplants. So we'll keep it fairly informal and hopefully have some time for questions afterwards, because what we're really trying to do is get the message out that this is an important part of what we do, and hopefully switch it on. That'll be a good idea. Yeah, there we go. There we go. Okay, so the first living donor transplant happened in Boston in 1954, and it was an HLA identical, a twin-to-twin transplant. And you can see the Herrick twins here, and this is the picture that's actually up in the Brigham and Women's Hospital where it was undertaken. And it was done by a plastic surgeon down here who was Joseph Murray. And Joseph Murray was awarded the Nobel Prize in 1990 for this particular procedure. So this was a tremendous medical breakthrough, really, because it was something that happened without any animal models. There was no ethics committee. There was nobody around to actually really put any constraint upon this procedure, and essentially it happened after the war because people realised that you could live on one kidney quite successfully, having had a kidney traumatically removed, and therefore potentially, as a solution, you could do this for end-stage renal failure. Because in 1954 we didn't have dialysis, so if you had end-stage kidney failure, that was really the only option, was potentially to consider a transplant. Now, not long after that, and this is March 1965, the first living donor kidney transplant in Australia was done here in Adelaide at the Queen Elizabeth Hospital. And this is just a bit from the news. And the donor, again, was a living donor transplant. So this is Dominic Centifanti, and he gave to his son-in-law here, Peter Tiramaku. And that was, if you like, an unrelated transplant that happened at the start of transplantation in Australia. So even early on, unrelated transplants were happening. And 2 years ago, we had a reunion, and luckily and thankfully, all of these surgeons who performed the original transplant, Mr. Peter Knight here, 50 years later, were all alive and able to come along to the celebration. And Professor Burt was very kind to allow us to do another Dean's lecture and talk more about transplantation at that point in time. So kidney transplantation, to make it very simple, can either be from a living donor or a deceased donor. but most importantly, they don't have to be related, and that's a critical thing about this. One of the things people quite frequently ask me is why we don't take the old kidneys out. We don't take the old kidneys out because that is technically a complex procedure, and often there's no really good reason to do it. And that they'll sit there, they're at the back of the abdomen, and Dr. Bhattacharya could talk about this later on. It's a big operation for very little gain. The new kidney usually goes down in the either right to start off with or left iliac fossa, so it's right down here at the front. And one of the reasons, correct me if I'm wrong on this, Shantanu, but one of the reasons that it is down there is that it's technically much simpler to connect all of the vessels to the recipient and then into the bladder. So we try to make an easy operation rather than a complicated operation. So if we think about what happens around the world, this is probably the most frequently, well, it is the most frequently performed transplant procedure. And between 70 and 80,000 kidneys around the world each year are transplanted. That's a relatively conservative estimate because we don't actually have very good figures on the numbers that are done in Russia and China and various other places. So it's at least 70 to 80,000, so it's a very frequent procedure. And as I say, we've been doing this since 1965. We can transplant all of these organs, and we're not going to talk about anything else today other than the kidney and the living donor kidney, because that's an important part of what we do in the transplant program at the Royal Adelaide. But to me, as a doctor, it really is a modern miracle, because it's the restoration of normal kidney function by taking an organ from one person and putting it into somebody else. Now, why this is so fascinating is that this is something that doesn't occur in nature. No animal system has this happen, so it's a completely man-driven phenomenon, and it's wonderful when it works, and it works very well. So who can be a donor? And Shantanu will talk some more about this at the end. We've got related donors, we have unrelated donors. We have this group of people called altruistic donors. Altruistic donors are very important, and Dr. Carroll will touch on this in his talk in a minute, because when they give a kidney, they can start off a chain of kidney transplants. And Rob will explain why that's really beneficial and how that can actually help a lot of people get transplants who wouldn't otherwise be able to get transplants. And that's through the paired exchange, so he'll talk about that. We won't talk about deceased donors today, but I will talk about blood group incompatible donors, because that's another advance that I think's really important in terms of how we get more people transplanted. So I tried to break it down and make it as simple as I possibly could. But if requirements for living donation in Australia, normal kidney function, 2 kidneys, you have to have 2 kidneys, we won't take you if you've only got 1, and no protein in the urine. If you start with that as a premise, then if you've got those, then that's a pretty good start. You certainly have to be hepatitis B negative, as we're currently working through, but hepatitis C and also HIV, in the past we would have said those were contraindications, but there are now programs around the world, because those are treatable and manageable diseases, where those donors have even been considered. So if you like, we're pushing the barriers on every conceivable front where we possibly can. So how old can a donor be? People often ask me this, and this is my old slide, and this is a patient of mine. This is Candace up here, and this was in the Advertiser quite a number of years ago now. And she was 18, and she received a kidney from Jerry here, who's her grandfather, who was 70 at the time. And then she went on this 70-year-old male kidney to have 2 children. So really quite remarkable. And she's still being looked after by us in the transplant service at the moment. He's now in his mid-80s with normal kidney function, having given a kidney back then. So who's the oldest? Well, the oldest is also a patient of ours here at the Royal Adelaide. And this is Marilyn over here, and this is Jeffrey. If Marilyn was here, she would tell you that it was very difficult when she came to see me, because she said, I'm 74 and I want to give a kidney to my husband. And I just looked at her and said, no, you're too old. And then I said, well, maybe you've got a 5% chance of being able to do this. And she was very determined, and she pushed at it and stuck at it, and she had all of those criteria that I said: 2 kidneys, no proteinuria, no other contraindications. And then after a bit of a battle, she was able to give to Jeff here. This is now 2 years down the track. He was 82 at the time he received this kidney, which is well above the normal that you'd expect. So this is the oldest living donor, recipient and donor couple in Australia. And I haven't been going to talk about it for the last couple of years, because I didn't want anything to go wrong. But it's 2 years down the track now, and things are going well. Okay, So transplantation, a modern miracle. This is really just to show you very large numbers of transplants done around the world. This is first transplant, second transplant, third transplant, and some people even get fourth and fifth transplants as they need it. And what you can see is that 5-year survival is actually very, very good, even when you have multiple transplants. So over 200,000 in this particular registry, with graft survival at about 75 or 80% at 5 years, which is really very, very, very good. Patient survival is better than this, but I haven't shown it in the interest of time. If you can have a related transplant, that's terrific. So if you've got an identical twin, which not many of us have, but if you do, they're a terrific source for kidneys. And you can see here again, very good 5-year graft survival, kidneys working very well in that situation. But if you've got a relative also, they do extraordinarily well, even with a small degree of matching. And if we haven't got that option, then deceased donation is an excellent alternative. But in my unit, I think what I'd like to think of us as a unit that puts transplantation first as an option rather than living donor transplant first, rather than looking at deceased donation, which we should use as a backup. So what about unrelated transplants? Now, I love this slide because it's got an interesting twist to it. So these are wife to husband, or husband to wife. I kind of hope that the husband to wife would be better, but that didn't work out that way. But the wife to husband and husband to wife, look at this. There's no relation at all here. Here are other live donors, about 10,000. And you can see that these unrelated transplants, genetically unrelated transplants, actually do better than those where there's a degree of tissue compatibility. And you say to yourself, well, how is that the case? Well, I've been married for 26 years, and I can tell you that if I'd had a kidney from my wife, she would be on my case every day saying, you will take your drugs. And I'm absolutely sure that is the reason that these transplants do as well as they do. It's that degree of compatibility there, and you're looking at the donor every day. So again, it's one of the reasons that we think this is a very acceptable thing to do. So what's new? I'm going to talk very quickly about the blood groups and blood group incompatibilities that allow us to that used to be a barrier, and we're now a barrier that we can get over and do transplant with. Rob's going to talk about the paired exchange, which is a really exciting initiative that the federal government has put in that's very effective in getting people transplanted. And then Shantanu is going to show you some keyhole surgery, how we get the kidney out, and also what we do to try to make things as absolutely safe as we can. I wanted to start just before everything acknowledging Mr. Mohan Rao, AM, because he was the first surgeon in Australia that introduced the laparoscopic keyhole surgery. And I can tell you at the time that he did this, he'd been overseas and he'd learnt how to do it in the States, and he came back and his surgical colleagues said to him, you are too old, what do you think you're doing? This is completely unethical, you shouldn't do it. And now I can tell you that every transplant that's done in Australia for living donors is done with this laparoscopic technique. So that was started in Adelaide 20 years ago. So it's at the Queen Elizabeth Hospital, so it's a really terrific thing. And at our celebration on Friday, or in 3 weeks' time, he'll be there to talk about it as well. Okay, so blood group incompatible kidneys. So we all know that we have blood groups, and there are different blood groups, and I'll go through those in a minute. But the important thing about it is that if you're a blood group A or a blood group B or a blood group O, you have different molecules expressed on the surface of your cells. And those molecules can be immunogenic. They can create an immune response. And so if you're a blood group A, for example, you can't have an antibody against blood group A, but you can have a blood group antibody against blood group B. If you're a blood group B, you have antibodies against blood group A, anti-A. If you're an AB, if you're lucky enough to be an AB, you haven't got any antibodies because you've got both of those antigens. And unfortunately, if you're an O, like 49% of the population, you'll have antibodies against A and B. And if those antibodies are present in the circulation, in the past, people who are blood group O have only been able to receive kidneys from other blood group O donors. But there are things now that we can do to manipulate the plasma, the blood, to get rid of these antibodies, to allow transplantation across that barrier to occur. So I'll just click through that. All right. The reason that we didn't do blood group incompatible kidney transplants is because of this man here. This man's David Hume, who was a very, very successful surgeon in Virginia and did some of the very early series of kidney transplants before anybody was really aware that the blood group was an issue. And the problem in 1955 when he did this was that 8 out of 10 of the transplants that he did in this very early series that were blood group incompatible all failed. And as a consequence of that, for the next nearly 40 years in the West, but less than that in the Eastern countries where there were other imperatives to transplant. We never did it. We didn't even think about it. In fact, I can remember at the start of my training in transplantation being told this is the absolute barrier that you cannot cross, and that I had to check 2 or 3 or 4 times that we had the correct blood group compatibility before we proceeded, and that was absolutely drummed into me. Okay. So the reason that these things cause a problem is that if you've got an antibody in the circulation, an antibody can bind onto the blood vessels, and then with this stuff called complement, you start to get little microclots forming. And those microclots block off the blood vessels that supply the kidney, and the kidney is lost from thrombosis. So that is why blood group incompatible kidneys up till recently have been something that we haven't been able to do. Blood groups are very interesting, and you might ask, well, why have we evolved these blood groups that are there to cause us problems with transplant? That's what I would ask. But in fact, blood groups are there because they protect us against other things. And so if you look epidemiologically, you'll find, for example, that people who are blood group O, for example, have higher prevalence of duodenal ulcers. The blood group A, which is quite common in Japan and China and places like that, much higher rate of stomach cancer. And A and B are more susceptible to smallpox. But what's really interesting is that blood group O is much less susceptible to malaria. And so one of the theories is that it was actually the prevalence of an infection that was actually driving the formation of blood groups. So this is where malaria is at high prevalence in the world. We know that malaria was around at the time that the blood groups formed, and the outcomes certainly correlate, or the prevalence of the blood groups correlate with the distribution of malaria. And so it's a plausible possible mechanism for it. So for example, if you look at Nigeria, sub-Saharan Africa, there's a very high prevalence of blood group O and very small prevalence of blood group A. If you go to Switzerland, where there's not a lot of malaria, there's a very high prevalence of blood group A and a much lower prevalence of blood group O. So the thought was that that might potentially be one of the mechanisms underlying it. So we have a protocol that deals with it, and I won't go into a lot of detail, but suffice to say that we give a treatment that stops antibody formation. We then perform a series of manipulations of the blood. We either take the antibodies, we take the plasma, which is the soup in which your red blood cells swim, and separate away the red blood cells and the plasma, throw the plasma that's got the antibodies in it away, and give back fresh plasma. So that's a depletion sort of step. Or alternatively, we use a very fancy little column, which I wasn't able to bring along. The reason I couldn't bring them is that they're worth $7,000 each. These particular columns we can put on, and the columns have got a lot of either blood group A or blood group B, whatever it is we want to get rid of, and we run it across like a dialysis machine. It gets stuck on the column and the blood is purified on the other side. And that's a very, very effective way of removing the blood antibody levels. And it's something that I think we can be very grateful to the state government for providing for us, because it works actually very, very well. So we have done all combinations here in Adelaide without any difficulty. This is the last 28 or so of these that we've done. So we've done a lot of blood group A's, done a lot of blood group B's, into usually O's, but occasionally A's into B's, and that sort of thing. So we've had a lot of experience with it, and all of these technologies are not experimental or research-wise. Now they're straightforward and easy for us to implement. Now obviously there are certain levels of these antibodies above which we won't do a transplant, but that's the sort of thing that we would work out when you have an assessment, and Shantanu will talk to you about the assessment process at the very, very end. So really, in summary, living donation is an excellent way of providing kidney function. Older donors, I think we're increasingly accepting. We can transplant across the blood groups now without, with treatment, and I wouldn't say it's easy and straightforward, but it's certainly doable and we can make it happen. So that's one aspect of it. What about immunological incompatibility? Well, this is where I hand over to Dr. Carroll, who will talk to you about new solutions that we've come up with to try to make those transplants happen a bit sooner. So Rob, you take over. I'm going to turn this on. You've got your... Good.
So let's see if this moves forward. Oh yeah, paired kidney exchange. So thanks for letting me talk to you today. And so I'm presenting some data that partly has been given to me by Paolo Ferrari, who's the current director of the paired exchange, but he retires or goes to Switzerland soon. So I'll present some of this data. So Toby's already mentioned about how long we think kidneys are going to survive, and this is a bit of data from Anne's data that shows the sort of difference between if you have a deceased donor versus if you have a live donor. And although there are some slight differences, it's this idea that you will probably do better in the longer term if you have a live donor kidney versus if you have a deceased donor kidney. And although there are a few issues sort of making these direct comparisons, the idea is that if you think about 5 years, then 90% of kidneys and patients are going at 5 years if you have a live donor, and 80% of people or kidneys are going at 5 years if you have a deceased donor. So there's this idea that you will do better if you have a live donor. And that's great, but I'm going to show you a bit of data that says that, just because somebody wants to give you a kidney doesn't mean that that's always going to happen because of either immunological barriers or immunology, or because of blood group issues that Toby's talked to you about. So sometimes you have somebody who wants to donate a kidney and they're blood group A, and you've already heard that if you're blood group A, you might have antibodies, and if they're low levels, that's great. We can fiddle around with you beforehand and make that happen, but sometimes those levels are pretty high, and we just can't do that. It's too dangerous. And sometimes we have people who could donate. Blood group O is a universal donor, and that's great, but sometimes the recipient has got antibodies to that person, and that can be through previous blood transfusions, that can be through previous pregnancies, and sometimes it can be because you've had a previous kidney and that kidney's failed and you've developed antibodies to that kidney. And so the idea in the paired exchange is that if you have these two pairs, then it may be that you can swap those kidneys over. And so the person in the top gives to the person in the bottom, and the two O's give to each other. And that conceptually is the idea that if you've got a blood group problem or you've got an antibody to kidney problem, then if you have people in a mix or in a group, you can essentially swap the kidneys over. So this has been going on for a while now, and particularly the Netherlands are usually pretty forward when it comes to making ideas happen. And so the Netherlands have had a paired exchange program for a while now. So is the UK. Canada has a national program, and we have had a program in Australia for a number of years now, and so is New Zealand. And then there's a few places around the world where they've got pretty much centralised exchange programs as well. So it's pretty much a worldwide phenomenon now. And it's a bit different in different countries as to why you have a paired exchange, or that the people who utilise a paired exchange do it for different reasons in different countries. And it goes back to a little bit about what Toby was saying in terms of that there are certain areas of the world that have particular blood group issues versus sort of not. And if you look at Korea and India, they're really utilising the paired exchange for blood group incompatibility, whereas if you move into sort of Caucasian and sort of places where there's been established transplantation for a period of time, then those people are really using it because the recipients on the wait list, or recipients of kidneys, have got antibodies to previous kidneys or previous pregnancies. So there's a slight difference between the different countries as to why and who's utilising the paired exchange program, whether it be for blood group incompatibility or for antibodies to kidneys, or what we call HLA incompatibility or immunological reasons. And this is a sort of a generalised schema, and it's pretty much represented in all of the paired exchange programs as the people in the program. Who are they, and what are their immunological problems? And we have this idea of signifying to people that they've got immune reactivity, and we call it a PRA, or panel reactivity. But really, and it's probably going to sound a little bit, sorry, go back, how is it, Toby? Is it the front? It's going to sound a bit scary, but what we say is that essentially in the people in the paired exchange in Australia, we have about a third of people have got antibodies to what really is 95 or 100% of the population. So the only way that these people are going to get a kidney is if they get a complete HLA matched kidney. So a third of people in the exchange have got antibodies to about 95% of the population. And you can already see that really it's going to have to be a twin, or if you've got a a brother or sister, they've got a 1 in 4 chance of being a complete match to you. So the people, a third of the people in the paired exchange have got antibodies to 95% of the population, either through previous pregnancies, previous blood transfusions, or previous kidneys. And then we have a group down here, again almost another third, and they've got antibodies to about 75 to 95% of the population. So you can see that they're also going to struggle. And then we've got people here who've got antibodies to virtually none of the population, low levels of the population, and about half the population. And they're usually the people who've got blood group incompatible problems, that their donor is not blood group compatible with them. So you can sort of see the group of people that were trying to help out by doing kidney swabs. And so if you think about trying to keep this schema going, that all of the pairs are all the same colour, so you've got a yellow donor giving to a yellow recipient and they can't give to each other for whatever reasons. And in the red there we've got an altruistic donor, so sometimes you have someone who comes along and I want to help somebody out the goodness of their heart. And so there are numerous ways, combinations and permutations you can try and get all these people to work together. And when we say negative cross-match, that means can we put these people together without an immunological reaction occurring? And you can make chains, so sometimes an altruistic person can give to this person and their donor gives to someone else, and the chain goes on. And what can happen is that the person on the wait list who doesn't actually have a live donor, they can actually end up getting transplanted because the altruistic donor started off a chain, and these chains can be 2, 3, 4, 5, 6, 7, 8, and they can go on and on and on in terms of a chain that goes down like this. So one altruistic donor can help out 7, 8, 20 people just by starting that chain to go. Or we can do sort of like a loop where it's not all in sequence, but you can essentially see how somebody gives to here, and this person gives back to the beginning of that loop or that chain. And then obviously goes back to that very sort of simple basic thing that I talked about at the very beginning. So I'm trying to just sort of show you that it isn't that simple, and there's a big computer that sits down and tries to work it out, and it churns away for hours on end trying to figure out who can be a match to whom. And really it's a bit complex, but really what happens is when we have all these people in the paired exchange, we try to help out as many people as we can. So if there are lots of different combinations and permutations, we try and make it happen that we help out more people over less people. And we have this idea of low probability of matching. So sometimes when we've got the same number of people, if we can find a person who's got a really difficult situation, we try and make the matches happen for that person rather than over everyone else, because they're going to have struggle getting. I won't mention number 3. And then we have this idea of trying to help out people who are blood group O, because they're the ones who struggle the most because they can't accept all the other kidneys, whereas people with blood group A can accept A's and O's. So we try to help out people from a blood group perspective as well. Now, it's all well and good saying we can have these huge chains, but when we talk about logistics and trying to organise theatre and trying to organise plane flights from Perth and Sydney and everywhere else, we really at the back of our minds want to try and keep things simple so chains don't break down, and that has happened. And then at the end of the day, if people have been waiting and waiting and waiting, we try help those people out as well. So that's sort of the hierarchy of the algorithm that occurs when all of these people put all of their data into this big database. Now, I'm trying to be a bit cheeky here, but the issue is that we started off very small in Australia with about 20 people in the paired exchange. And the way that it works, for virtually all of the exchange program, there's a critical mass that once you get to 50 or 60 pairs of people, then your probability of match goes up to 40%, and it doesn't really increase the bigger that those matches go. And so that's just to show you what's happened in Australia. And so what did happen in Australia over time, so it's sort of 2010 here up to 2017, you can see that the people in the exchange has risen. And so we are getting to this sort of magic number of 50 or 60. But the other issue is that we are actually seeing people staying in the program who haven't managed to get a match yet. So there are swings and roundabouts. It is a good program, but it doesn't always win for everybody. So this is a bit of data from the Netherlands, and what I'm just trying to show you here is that these got 60 or 50, 100, 150, 50, so they're all getting to this realms of above of 60 pairs in the group, which means it's a sort of an efficient way. And sometimes we move the donor, and sometimes we move the organ, and it doesn't really seem to matter whether that happens, but in Australia we decided to move the organ, not move the donor. And a little bit complex here, but what I'm trying to get across is that there are many ways to do things. You can transplant in those loops that I told you, or simple two ways, or multiple way swaps. And we call these non-directed donors or altruistic donors. And you can see in Canada, for example, they have utilised a lot of altruistic donors in order to get their program to work. And so it's just showing you that although all of these countries have different exchange programs, there are slightly different ways of doing it. So again, transplants from loops, we seem to be very good at that in Australia, and the Canadians use altruistic donors. And so this is the comparison of all the live donors that occur in Australia, how many are actually being transplanted through the paired kidney exchange. And that's sort of reaching a sort of a 15 to 20% mark over time, and it sort of seems to stabilise. So the expectation is if you come along with a live donor pair, that you've got about a 1 in 5 chance that you'll end up maybe requiring the paired exchange to make a successful transplant occur, either because your blood group is incompatible or because you've got antibodies to your potential donor. And this is some early data from the AKX, or the Australian paired exchange, and it's just saying that in the early phase they're doing very, very well. But there are issues, and as I mentioned, you can sort of see that the group is getting bigger because there's some people who are staying in the paired exchange program. And what this red group is showing you is that early on in the program they had people who, again, these are people who've got antibodies to 97% of the population or potential donors. They were a small group in the group to begin with, but they are not getting transplanted in the paired exchange, and so they're becoming a bigger and bigger group of that paired exchange program. So that's one of the negatives of the paired exchange program. It's not working for these people who are really sensitised. And there are plans afoot to really think about how we go about attacking these issues in the paired exchange program. So again, this is the data you've seen before, that we're doing okay and we're getting new registrants every time, but there's a group of people who are just not getting transplanted. And so recently, looking back at all of that data, the paired exchange program has been able to develop a program now, which is quite new, and we can sit down and sort of figure out and tell people when they come, what's the probability of you getting transplanted? Well, if you're blood group A and you're sort of sensitised below 97%, then you've got a pretty good chance of getting transplanted in the next couple of years, considering the whole reason you're in the AKX is because it's difficult to be transplanted. But if you're a blood group O and you've got 97 to 100% PRA, then you've only got a 17% chance of getting transplanted in the next couple of years. And that's good because these people ordinarily wouldn't be able to be transplanted at all, but it's showing you that for some people, even the AKX is a bit tricky. So we talk to everybody about the paired exchange program. We think we should be talking about paired exchange program to all altruistic donors, because rather than just a straight swap, they could actually go into the paired exchange and allow 7 or 8 or even more people to be transplanted. But we have got this issue of people who are very highly sensitised, that even the paired exchange doesn't seem to be working for. So I hope that I've given you a bit of an idea of what we're doing in the paired exchange program. It is a great program, but there are a few times when it doesn't quite work for us. Thank you.
Greetings. My bit's not going to be quite so into the medicine parts of it, but I shall talk a little bit about kidney transplant and organ donation. And really the question that begs to be asked is why transplant? Because if you have kidney failure, you have choices of dialysis, and you have hemodialysis, peritoneal dialysis, or you have kidney transplants. And so why this big push on transplant? And one of the sad things about renal failure is that it's a disease that tends to isolate people, primarily because there are just so many restrictions in what you can do, what you can eat, what you can drink. And in terms of social activity, going and eating socially and stuff is quite important. And if you can't do it, it's very boring sitting there with some salad while everyone else is having steak and chips. And so that's one aspect to it, that it is very isolating. And for a lot of patients, your social interaction is your dialysis club. And everyone meets up, hooks up, and make very good friends, and often will share notes about what the doctor told them. The second, from the economics perspective, if you were on dialysis, the cost of dialysis every year is about $50,000, give or take a few dollars. And if you had a successful transplant, the cost of a transplant in the first year is about $50,000. However, in the second year after your transplant, the cost of your transplant care is only $14,000. So from the government's perspective, and whoever is footing the healthcare bill perspective, transplants are a huge success. But more than that, as a transplanter, apart from the quality of life and the fact that it saves pennies, what actually attracts me more to transplant is it does give a survival benefit. Now, quite a few years back, I think around 2000, Haller and al. Published from the US, looking at the US studies, and said that in diabetes, you almost double the life expectancy of a person if they have a successful transplant. A similar benefit was seen with other organs, with other conditions, however, did not reach the same degree. We actually have better data now. And what we do see here, sorry, it's a little busy, but it essentially shows for each age group this is again US data, is what the expected survival is if someone stayed on dialysis, male or female, what that becomes if they have a transplant, and what it is in the normal population. And what we can see is that a successful transplant significantly improves survival, even when we are between 75 and 79 years. We end up gaining about 4 or 5 years compared to staying on dialysis. The types of donors, they could be deceased or they could be live donors. We're not going to talk much about deceased donors. But living donation can be either directed, where you know the individual you're donating to, or it could be non-directed. The non-directed is the true altruistic donation, where there is no motive apart from altruism to wanting to donate. In directed donation, it could be someone who's related, which means genetically related or unrelated. I suspect why more wives donate to their husbands than the other way around is probably because a sick husband means that the wife's life follows the pattern of the sick husband, and is taking the husband to the dialysis unit and bringing back, and really they don't have a quality of life either. Whereas if it's the husband, he just goes to the pub and has a drink while his wife is on dialysis. Sorry, no disrespect meant to anybody. Also, why the interest in life donation? One thing we have seen over the years is that kidney failure incidence is on the rise. Part of it is because we live longer, so we are having more people who are coming towards when people died at the age of 35, tuberculosis was a good enough cause to kill quite a few of them. When they live up to 80 or 90, we find cancers, chronic conditions which start becoming more prominent. And so renal failure is on the rise. There is a huge gap between the amount of organs that are available with deceased donation as compared to what the need is. As Rob has pointed out, the outcomes following live donation and live donated transplant are superior. But what one has to consider is that actually the live donor doesn't need an operation. This is someone who's perfectly healthy out there in the street, living a perfectly normal life, and he has an operation, which carries some risk. So if someone had a cancer and you operated them and there was a certain risk to be taken, but there was a very clear perceived benefit that you were getting rid of a disease or you were getting rid of a condition. But for the live donor, and in the context of kidney transplantation, the recipient is always happy when they get a transplant because they are free of dialysis. The nephrologist is happy because he's taken his patient towards good health and cure. The surgeon is happy, he's got a bit of plumbing to do. The only person who's left with a feel-good factor is the donor, because they have actually taken a lot of risk on. And so there has to be a balance between the risk that a person takes and the benefit, the emotional benefit that you get or achieve by doing that act. And therefore, when truly non-directed donation first started and people started coming out of the woodwork saying, we'd like to donate, we were quite comfortable when people were in their 50s or 60s, completed their family, finished their responsibilities, have come to know of renal failure, wanting to donate a kidney, and they were in good health, and we were quite happy doing it. Then we had people who were 20 years old coming forward saying, can I give a kidney? And that becomes a bit more complicated, because while we do know what the outcomes are 10, 15, 20 years after donation, when you suddenly have to consider what happens 60 years after donation, it becomes a little more difficult to sort of predict, because none of us have a crystal ball, and transplant's only been there since 1965. So we haven't gone that long yet. However, there is some data out there. So this particular slide actually compares live donors and deceased donors, and also compares elderly live donors to deceased donors and younger live donors. And what is interesting is that the first bit talks about failure of the kidney. And so the older the kidney, there's a higher chance of failure compared to a younger kidney. However, when you look at the years of survival post-transplant, what's quite interesting is that a live donor kidney from a donor who's over 70 years does better than a standard criteria deceased donor kidney. So that donor is about 50 years old. So I think this data has only recently become available. So the boundaries are constantly being pushed, because one, we are understanding that it is safe, and two, we understand that ultimately whether a person should have a kidney transplant or not has to be balanced against what is the risk to that individual staying on dialysis versus going on with a transplant. Because when you have two risky propositions to choose from, you have to always choose what will give you the better outcome. And this data has also come up quite recently. Now, there was some concern about live donation actually affecting the long-term health of the donor. And what this data shows, the thick line is live donors, and the dotted line is matched control. So these were people who were as fit as live donors, but actually did not go on to donate, right? And it looks at the mortality. And the people who ended up donating had better mortality than not. And so you turn around and ask me, well, how could that be? So really, it's like a motor vehicle check, that when you come forward to be a live donor, you have a 70-point check done, which is not done on your peers. So your peers, unless they've come forward to come through that and jump through all the hoops, really don't know whether they are well or not. I mean, until you have that blood test, if you are a diabetic, you wouldn't know whether you're a diabetic. It's only after the blood test is done that you know, hang on, there is a problem here. So, does age matter? Because that's one question, that if you have a very young donor or you have an older donor, how do they compare with their peers? And again, this is recent data which now has looked at cumulative survival managed by age criteria. And so we have less than 18-year-olds, 40 to 49, 50 to 59, and more than 60 years. And what it does show is that we see the trend of better survival regardless of which age bracket the donor is coming through. But again, the data only goes up to 12 years. So very difficult for me to look into a crystal ball and say what will happen in 60 years. Does sex matter? For live donation, apparently not. Whether you're a male donor or a female donor, your long-term survival is not hampered by the act of donation. So is it dangerous? If an individual is fit to donate, then it's probably not dangerous. However, to be able to donate, we do carry out a very stringent set of tests, and you just need to fail in one to be taken off the entire thing. And that's really because when we assess you as a donor, even though we do transplants and that's our livelihood, we do not think about the recipient at all. It is the donor's safety that is paramount, and we will always put the donor first simply because the donor doesn't need that operation. So the assessment process is not just one person, it's a lot of people together, and sometimes it will be more than the nephrologist or the transplant surgeon. Sometimes we'll have urologists looking at a person, we'll have a cardiologist looking. So we, to the best of our ability and to the best of current technology that allows us to assess a person's health, we will make sure that we do not leave any areas of doubt or shadow before we say, yes, we'll go ahead with an organ donation. And then we have independent assessors. And that is really to make sure that there is no coercion, there is no financial incentive or that lovely holiday in Bahamas that was promised, that the donors are aware of the risk, and there are risks. There is a 1 in 3,500 risk of dying, probably less than the risk of dying while crossing a street in Adelaide. However, there are risks, and so when someone goes into wanting to donate an organ, they have to do it with their eyes open. And the rest are fairly straightforward. So, a bit about the operation that Toby promised, and I hope this works. It didn't at that moment, so we will try again. It shall work now. Yeah. So laparoscopic surgery revolutionized the process. That's a bit of colon being peeled off the left kidney, and that's the kidney there, and the bit that came off first was the colon. The kidney lies right at the back. And what laparoscopic has enabled us to do is really move the incision from where we remove the kidney from a very uncomfortable position just below your ribs to above your pubic symphysis, something like a C-section. So it has allowed people to recover much faster, and that's a vein being clipped off, and make an earlier recovery and have less post-operative pain. And so that is what has allowed a lot more appeal. Live donation has become suddenly a lot more appealing than what it used to be previously, because previously if you were a live donor, you would have a cut starting at your back going almost up to your belly button, and now you just have a cut about that big. And so that has made it a lot more appealing, and the cut is in a nice place. You could still go out in a bathing suit and nobody would know that you'd had a big operation. And that surgeon is very carefully dissecting out, that's a vein, and that's probably one of the veins going down to the testis there. And what you can see is the vein on top, the blue, vein, venous blood is blue. Actually, it's not quite blue, but the bluish structure is the vein, and the one below there, which is pumping away, is the artery coming off the aorta. So if you can, with the eye of faith, you can sort of see it's like a T-junction. The horizontal bar is the aorta, the big vessel that comes from your heart down to your legs. And that's a bag in which the kidney is being collected. And after that's done, we divide the vessels and take the kidney out. Once the kidney comes out, it is cooled very rapidly to preserve it, and so that, because obviously any organ needs oxygen to survive, so the kidney comes out and we cool it down very quickly so that it does not have that requirement of oxygen. And we are able to preserve it in some special solutions, and then we get the recipient ready and the transplant happens in the recipient. So at this stage I shall move on to the next one, because that's just... And so what were the recent advances from a plumber's perspective, which is what a transplant surgeon is? One is safer anesthesia, being able to do laparoscopic surgery. We use enhanced recovery protocols, so now we are reaching a situation wherein previously patients would stay 4 or 5 days after they had donated a kidney. We are now being able to get them home 2 days after the operation, which I think is a good advance. And also the advances of being able to go across blood groups or treat people who have antibodies against their donor, where previously we would have said not suitable for a transplant. So I think lots of little steps have contributed together to allow us to push kidney transplant further forward and life donation further forward. So who do you call? You call the life donor coordinator in the Royal Adelaide, and their numbers are there on the cards out there if anyone wants them. And once we will not go and ask someone to donate, because then in theory we are coercing. But if you did wish to donate, you could. Now I know that in this audience there are some of us who have renal failure or who have pre-existing renal disease. But you could still be an organ donor on the deceased, and you could sign up to donate your organs after you die, because it's just not the kidneys or the liver. We've got lots of tissues. People are helped with corneal transplants because they go to restore vision, and there are lots of things that can be donated in terms of tissues or organs, both in life and in death, and so it is something to consider. Thank you for your attention.
Well, thank you all for these very clear, excellent presentations. I think there's time for just a few questions. So, anyone want to start? Yes, please.
It's very widely available, and we've been doing it since 2006, so it's 10 years worth of experience, and around the world it's been probably some of the centres started a few years before us, but very, very well established now.
Yeah, please.
For last speaker, well, I'm curious to know what's the time frame between, say, removing the kidney and putting it into the recipient? You said you cool it down, but I imagine that maybe it could be 10 minutes or half an hour.
No, so
but is it completely?
it depends. It depends which part of the world you are in and what you have available. So there are some parts of the world where they have 2 theatres that run simultaneously. So you have the recipient open in one, the donation happening in one, it's flushed and put straight in. You have places which do it sequentially. So how long can you keep a kidney on ice? Right. And people have done transplants as long as 48 hours after the kidney has come out. The kidneys do work, but they don't work as well as they would have worked if that cold time was shorter. What the data suggests is that after about 8 hours, for every additional hour that it's sitting on ice, you get a certain deterioration in the kidney function. What we try and achieve here is we get the donor done and then we go ahead with the recipient. And our cold time is roughly about 3.5 hours between kidney coming out and going into the recipient. And most of the kidneys will work straight away. 1 in 10 kidneys with live donors, 1 in 3 kidneys with deceased donors tend to be a little sleepy to start with, and they just need a little while to bed in and recover from the shock of having come out of someone and gone into somebody else, and may occasionally need a bit of dialysis to tide them over. But with live donation, most kidneys will get going almost straight away. And someone who probably has not produced any urine, it's not surprising to find someone who's not produced any urine at all suddenly peeing about 7 liters overnight. It's that dramatic. And that has its own problems, because while you're in renal failure, your doctor's been telling you 500 mils and no more, that bottle of water and no more, and suddenly the same doctors are coming and telling you, you've got to drink. Come on, you've got to do better than this. So yes, it's quite dramatic, but it does settle down.
Yes.
A question for Rob. In Australia, how many people are altruistic donors? And if you wanted to have sufficient numbers of people to be able to stop there being a waiting list, how many altruistic donors would you actually require in Australia?
Oh my gosh.
Just a quick calculation. If you can do a rough thing.
Take that one on notice.
I take that one on notice. I mean,
We're looking at hundreds or more?
gosh, it'll be really interesting. I might take that on notice, as you say, but we haven't had an altruistic donor in South Australia for 5 years, 6 years. It's a lot more common in Canada. It's a lot more common in the UK, actually, and that's interesting, because you would have thought they're sort of very similar sort of demographics. But I'll sort of go back to the UK and Canada every sort of 4 or 5 years, and it's really interesting how different it is. And that was me trying to show you how different, with Canada being there, and I probably should guesstimate from those bar graphs and those numbers that it does actually help your program considerably if you've got a lot of altruistic donors, and that's what's happening in Canada, and it's really quite common in the UK now, and it just doesn't seem to be happening here.
I think there was a big push by the government in 2009.
Yeah.
And the government came out very strongly advertising altruistic donation.
Yeah.
And there was a lot of uptake.
So it's an educational thing.
Yeah.
Is that being considered here?
I think the one thing that's happened here is that the government or the organ donation authority is very keen about removing barriers to live donation first. So we do actually have we have sort of a loss of income type thing, which is at the minimum wage. But there's lots of ideas about saying, do you get free health insurance? Do you get those are the type of things. So there's lots of thoughts about removing barriers to live donation, and I think the next step would then be removing barriers to altruistic donation. There's recuperation time. There's all the time it takes you to have workup done. You have to come in and out and have tests done. So there's a lot of work that goes in a live donor to be assessed, and that means time off. And some of these people are using sick days to come in and have testing. So I think a lot of it is about removing barriers to live donation.
One last comment from...
Just going to add that in some states, altruistic donation is illegal. So, believe that?
In Australia?
In Australia, yeah. It's a state to the north of New South Wales.
So, on that note, I think we'll... if I may, I'll just make 3 observations. The first is that as a young medical student, I used to take blood in the mornings in the renal transplant unit in Glasgow. It's a few years ago, and I can tell you that renal transplantation across that period of time has remarkably changed. My second observation is you've heard that actually Adelaide has contributed considerably and continues to the further development of renal transplantation. And the last is that I think renal transplantation is not alone, but it's a fantastic example of the real multidisciplinary approach to the management of a chronic disease. You've heard that already this evening, the involvement of surgeons, physicians, renal nurse practitioners, but also immunologists, all the important stuff that you heard at the beginning, biochemists and so on. And it really has been tremendous advances over, as you've heard, not even 60 years. So thanks to all three speakers. I'd like to ask you all to acknowledge your thanks for what I think has been a remarkable evening. One last thing. I thought, you might have thought when I was going over the piano I was about to give you a rendition, but it's not. Thank you very much.